Welcome back, everybody. I'm really excited to be here today. You are all experts in sonography, but today we are going to discuss pediatric abdominal emergencies and the point of care ultrasound in the pediatric emergency department. The purpose of today's lecture is going to familiarize you with using POCUS in pediatric abdominal emergencies and encourage you to start the scanning early in the ED, even if you're going to end up sending the official anyway, because you should practice this because these are skills that you should have. Just as you feel comfortable scanning kidneys, gallbladders, and hearts, we should get more familiar with scanning abdomens, looking at intestines to know what normal intestines look like. And that's a perfect segue in to where we're going to start. So ultrasound of the bowel is challenging. It's not surprising that it's so challenging because you literally have a moving target, something that's peristalsing, but you also have something that's filled with lots of gunk, filled with fluid, filled with air, filled with stool, and it can always make your bowel look a little bit different. So the idea in pediatric POCUS of the abdomen is to know what normal bowel looks like and to be able to differentiate what's normal and what's abnormal. So normal small bowel is generally small caliber, has fluid and peristalsing. And then generally with the peristalsis, you should see that the peristalsis is all going in one direction. If you're looking at small bowel and you're seeing peristalsis that's wishy-washy back and forth, that should perk up your ears and you should say to yourself, is there obstruction? That doesn't sound right. And then in the small bowel, you also have the valvulae convientes, connivientes. I can never pronounce these words. But these are kind of the invaginations of the normal small bowel wall. If you remember from like imaging days back in radiology, it would always have been like the feathery appearance of the small bowel. But that's what the valvulae convientes are. When you move on to your colon, you generally see the visible haustra. You see your large luminal diameter, but you often see like a lot of gas. That gas can show up hyperechoic, so you have some bright spots, and then you see your poo. And poo on ultrasound, again, looks very hyperechoic, and it looks very different, and obviously it's not really going to move. In normal bowel, if you're really lucky, you'll see the classic 5-layer bowel wall. Now, this is really cool because occasionally it may be confused for surrounding free fluid around the bowel itself. But normal 5-layer bowel wall has this kind of double Oreo look to it, inverted Oreo, white, black, white, right? Starting from the out going in, serosa, muscularis, submucosa, deep mucosa, superficial mucosa. This looks really, really cool if you can see it. Now, the key here is that normal bowel, you can occasionally see this 5-layer wall, but when you have a sick kid with an inflammatory process, that bowel wall will often be obscured due to inflammation. So if you're saying, well, I see this tubular structure and it doesn't have a 5-layer bowel wall, that might just be because of the inflammation. And don't feel bad if you don't see it, but this is a really cool finding that you see in normal wall. Beyond this, most bowel is collapsible, right? You should be able to compress your bowel because you know that there shouldn't be anything that's causing such large intraluminal pressure that prevents you from pushing from the outside to collapse that bowel itself. Now, this is what normal small bowel can look like. This is not a video, this is just a still. But when you look at that small bowel, you do kind of see the multi-layered bowel wall here. But kind of the key here is that you see the valvulae convientes. You see kind of the multiple invaginations where all of your absorption happens within your small bowel. Moving from small bowel, it's pretty obvious when you see this and then compare it to large bowel, right? Large bowel, you often end up showing your haustra. And because large bowel is often filled with air or stool, you may end up with artifact beyond the bowel wall itself. So this is a good picture of the haustra where you see great haustra, but then you don't really see contents because there's some amount of air, there's something that's causing an artifact that's not allowing you to see the intraluminal contents. As opposed to small bowel, where you may see the contents more readily because it's usually more liquidy and you're not getting artifact from air or stool. Looking here on the right, you see kind of what looks like a normal cecum terminal ileum to the cecum connection. If you're really good at bowel ultrasound and you're looking in that right lower quadrant, you will actually be able to identify the difference between your ileum and your cecum. I recommend trying to find this. It is not easy, but it is definitely worth the effort to see if you can find it, because as we'll talk about in a little bit, you can have some appendix coming off your cecum here. And if you know where your ileocecal valve is, it helps you identify some of your landmarks. But the key here being large bowel is very haustra-filled, while small bowel is not, and has a lot of peristalsis and a lot of moving contents. What do you guys think this is? Anybody? Bueller? Anybody? So this is what stomach looks like on ultrasound, okay? Now, it does kind of look a little small bowel-y because you have some of the invaginations, but these are your rugae within the stomach itself. When you have a really high quality linear ultrasound probe and you're looking in that left upper quadrant, you may often find your stomach while you're looking for things like your spleen and your kidney. Your stomach will have this kind of invaginated appearance, but you will also see some stomachs that just look like a lot of hyperechoic bright spots, because that looks like, this is a good example of kind of when you have the antrum of the stomach where it's just filled with contents. It's obviously not such a linear probe, so it doesn't have such great resolution. But what you can see is that you do see some of the intragastric contents that kind of have these hyperechoic speckly appearance, and that may confuse you when you're looking in the left upper quadrant. But again, it's really important to know what normal looks like so you can then identify your abnormals. So this is kind of a video of what like normal ascending colon would look like. Now I'm gonna try to slow this down because it's very quick. But as you're looking at the normal ascending colon, you're seeing your haustra. You're seeing that you have some of the haustra up here. You're seeing that air reverberation artifact behind the haustra itself, because there's some type of air or some type of stool or something in the colon itself that's blocking the normal posterior view that you see, because you see all of these artifacts. But this is just another idea of what normal ascending colon looks like. So let's go through exactly what we're going to talk about today. I chose to pick intussusception appendicitis because these are the things that are always on our differential for a kid that has belly pain, and we want to be more comfortable with the ultrasound procedure with evaluating for them. So let's start off with intussusception, right? It's like a bowel within a bowel. Your intussusception is the case where you have invagination or telescoping of bowel onto itself. In this situation, the most common age group for intussusception is usually from 6 months to 36 months. Older than 36 months, the rate usually drops pretty precipitously. This block here over at the right does show that younger than 3 months is very, very rare for intussusception, like less than 1%. And that once you get over 5 years of age, it drops to maybe 10%. And when you get even older, past 10 years of age, it drops into the single digits. So most of your intussusceptions you're looking for in that 6 to 36, or you could say 6 to 2 year age group. And as you get older, the rate drops off pretty quickly. Interestingly enough, boys have this twice as often as girls. Don't ask why. But the most common location of this is the ileocecal valve. This is your ileocolic right lower quadrant intussusception. This is more than 90% of the cases, but you can have other stuff too. You can have ileal, jejunal ileal, colocolic, etc. There's all different versions because obviously any part of the bowel can kind of telescope into itself. Now, the most common cause of intussusception is because you have some amount of precipitating virus that causes inflammation, causes lymphoid tissue hyperplasia in the belly, and then that causes a lead point that allows the bowel to telescope into itself. Now, these are the most common types of lead points, but there are pathologic lead points, i.e. tumors, polyps, cysts, Meckel diverticulae, things that are definitely scary that have to be included on your differential as the reason for this child having an intussusception. And we'll talk a little bit more about that moving forward. What does this invagination actually look like? I love these pictures because it shows you in schematic form what it looks like when a piece of bowel telescopes into another piece of bowel. Here up at the left, you see that intussusceptum telescoping inside the intussusception. And you can see that it pulls the mesentery inside with it. And on the right, you can even see it even better. This is a small bowel one, but it pulls excuse me, it pulls the mesenteric lining and it pulls the vascularity inside this little invagination, this telescope piece. And that is where our problem creates itself. When you have this telescoping and you have the vascularity getting sucked inside with it, that's where you end up with bowel necrosis, bowel death, and perforation and really sick children. Now, at this point, it's really important to remember that when you have an intussusception, you often have that sometimes the telescoping goes in and out, but often the telescoping has already happened, and the classic intermittent painful episodes occur because there is peristalsis of the bowel against the telescoped segments. So even if your patient is not having pain, you may see the telescoping bowel on ultrasound, but their painful episode will generally happen when the bowel starts to peristalse and hit this obstructive piece. That segues perfectly into what do these kids look like. This is the classic crampy, intermittent belly pain, usually associated with bringing the legs all the way up into that abdomen or the chest. And that in general, patients can be entirely asymptomatic between these painful episodes. But it's when you have that peristalsis that they develop these acute painful episodes. So you have to be very concerned in kids with intermittent belly pain, especially in the appropriate age group. If you see current jelly stools, you have already missed the boat. This kid is super, super sick already, and they have some amount of severe disease, because if you have current jelly stools, you're already starting to necrose the bowel. And that means that this kid is super, super sick. Interestingly enough, there's a thought in intussusception that when you have the telescoping of the bowel and you end up with some amount of bowel ischemia, that you release endogenous opioids into the bloodstream. And this makes your kid with intermittent crampy episodes and lethargy very, very scary, because you have to be concerned, is that lethargy because they have intussusception, or is that lethargy because they have some kind of a meningitis? And when you have a 6-month-old, 7-month-old that has altered mental status and is lethargic, intussusception still remains on your differential, in addition to overwhelming sepsis. Some surgeons will say that you can palpate a mass in the abdomen, especially if you have an ileocecal intussusception, but this is pretty rare. And I've had surgeons say that you really can only feel these type of things when the patients are paralyzed, so that they have none of their abdominal musculature tone. That's really the only time that you can feel it. So don't hang your hat on feeling an intussusception. Now, how you actually...
Sorry, I was just gonna echo Adam. Lethargy is a more common presenting symptom if you're less than 6 months of age. I definitely saw a kid in residency who just presented, like, the remarkable thing for me on her exam was her hypotonia, even though she was a 5-month-old, and it ended up being intussusception.
Yes, thank you, Rosie. That's a very important piece to make here. Those endogenous opioids make them very lethargic and very scary looking, but make sure that you have appropriate concern with a broad differential. If you think intussusception is likely on your differential diagnosis, you are smart if you grab your ultrasound probe. But before you even do that, there is a non-invasive test that you can do that's not even going to take that long, where you can get a 3-view abdominal x-ray. Now, this is something that I was never taught through my entire residency, and it was only when I came to fellowship that we talked about this. But if you get a supine, prone, and left lateral decubitus 3-view film on your baby, and you find air in the ascending colon in all 3 of those views, you have 100% sensitivity that this is not an intussusception. Now, it is very poorly specific, but if you find that you actually have air in 2 or more of the 3 views, you have a little bit better specificity for intussusception. But the key here being that if you have an ileocolic intussusception, you will not have air in the ascending colon above the ileocolic valve, like the ileocolic junction, and that you will not see the air on abdominal films. But this is a really quick way to just throw the patient into x-ray and say, well, what do I see? And if your abdominal x-ray is abnormal, then you can go ahead and start looking at ultrasound. Ultrasound, when done by a trained provider, obviously gets up to like 100% sensitivity and specificity, and that if you have the appropriate person doing it, you can even have like 100% negative predictive value if your ultrasound is done very, very well. And what you're looking for here is that classic target sign. And let's go through some examples of what this really looks like. So how do you actually do the intussusception ultrasound? You don't just start poking at one individual place. You start usually at the right lower quadrant, and you use a wide linear probe. In pediatrics, we have kind of that 1-inch wide linear probe that's really, really small. If you have the time, run over to the main and grab the adult wider probe. It'll give you a bit of a wider window to look through, and it'll help with your visualization. And now what you do is you use mowing the lawn. You got to mow the lawn. And this picture kind of shows what you do. You track up the ascending colon, you go over, you come down the ascending, go over and up, and you go in this zigzaggy pattern. And then once you reach the upper right, upper left rather, then you go back and you reverse your mow the lawn and you go the exact opposite way that you did it the whole way through. And this allows you to look at all parts of the bowel. At the same time, we're using graded compression, which is a fancy term for push hard with consistent pressure to help make sure that the bowel gas is pushed out of the way so that you can see the intestines without artifact. Now, let's see an example. So this here you can see is labeled, and this is a thank you to Dr. Drennis for some images while he was up at LIJ. When you're doing the mow the lawn, you can label which part of the abdomen you're looking at. So this is right lower to right upper. Now it's a little bit quick, but does anybody see anything interesting? I'm gonna keep playing it. Oop, I'm starting to see something that doesn't look so great.
Adam, you can pause it, play it a little bit,
yep,
pause it,
and then drag it.
Yeah.
Yep.
Like pause it now.
Yep, it's paused and just dragging. Thanks, yeah. Tasso.
Yep.
So as you're going up the ascending colon, all of a sudden you start to see kind of your bow, and then bam, all of a sudden you start to see this. Where did it go? You start to see this circular structure popping into view that kind of looks sort of like a target. You see that you have an outer and an inner, and it looks kind of like a target sign. This is your intussusception that you've identified, and you're patting yourself on the back because you found it. When you do find an intussusception, you always want to make sure that you view it in 2 views, transverse and longitudinal, so that you can catch it looking in 2 different views to make sure what you're looking at is what you're actually thinking is there. This is another zoomed in picture of what that intussusception looks like. So you can see that classic targetoid appearance. And as you advance through it, you really see that this is like the bowel that's invaginated upon itself. And as you keep going through, it looks pretty obviously targety, especially right here. It's a fantastic shot. Thank you, Dr. Tasso. When you go in to do something in a more transverse versus longitudinal view, you can see rather transverse, you see your target. Longitudinal, you'll start to see the actual invagination. This is a still of what that light looked like. So on the left of the screen here, you can see that you have the standard target sign with a nice little overlying target. But at the left, you see kind of this grainy looking longitudinal view where you see the bowel actually invaginate upon itself. And this is really classic for intussusception. This here is another video. This actually shows sort of like an oblique-ish view where you do see some of the invagination. So you can see here you have your standard target sign, but over here you kind of caught it on a little bit of an angle, and you start to see that it looks a little bit invaginated. And if you play all the way through it, let's see if it'll loop again. You do see like that classic target sign with the invagination of the intussusceptum within the intussuscepiens. Now, interestingly enough, when you're going through and doing your ultrasound for intussusception, you may find something that looks like a kidney. I remember Dr. Shah, during her fellowship last year, walked into a room where they were ultrasounding a kid's belly, and she said, "Hey, that looks like a great kidney," because she was coming in and only saw an instant shot of what it looked like, when in reality, what she was looking at was a pseudo kidney, which you can see in kind of the oblique or long axis view that shows kind of this invagination of the intussusceptum within the intussuscepiens. and shows what looks kind of like a kidney. It's very, very interesting. And if you go back to this first view, this beginning piece looks like a really irregular looking kidney-like structure. And that looks like a pseudo kidney. And then as you then rotate your probe a little bit and move around, then you get your full true target sign. So this is just something that you can use to help convince yourself that what you're looking at is not a kidney and actually something else. Now, the key with ultrasound for intussusception is that if your POCUS ultrasound is still negative and you have a high suspicion, please go ahead and get the official ultrasound. We are good at ultrasound, but not as expert as our techs. Now, we want to make sure that we get the official so that they are doing a thorough examination of the entire abdomen and really getting a look at everything to make sure that we're not missing it, okay? Now, what do you actually do once you identify your intussusception? Generally, we use a hydrostatic or pneumatic pressure enema, and this is generally for your clinically stable patients, no perforation, no shock. These are the ones you call radiology. Radiology will come down and do a pneumatic enema and just literally pop the intussusception out of itself, okay? It'll just push the telescope segment out of the outer segment. If you have a patient who is unstable and you're concerned that there's any evidence of necrosis, perforation, peritoneal signs, you want to make sure that you have surgery on call immediately available, that if you were to attempt a air reduction and there was a problem, you would immediately be able to go to the OR. But if they're so hemodynamically unstable and you are so convinced that there's signs of perforation, you just want to take them immediately to the OR itself, because they want to open up the belly and make sure that they can assess for necrosis and make sure that they're assessing for any other bowel injury all at the same time. So what do we do here at Kings County when we have an intussusception? Now, we reviewed it a little bit a couple of weeks ago at one of our past conferences. But if you start to think that you have a stable patient and you're thinking that there is a possible intussusception, put it in an IV, get some appropriate analgesic going on board, and then you want to notify your attending in the ED about it. You go ahead and you initially get your x-ray, your 3-view, supine, prone, and left lateral decubitus. And if your x-ray is suspicious or your x-ray is negative and you still have high clinical suspicion, you go ahead and you get the official ultrasound. If the patient is unstable, obviously you immediately resuscitate and notify ped surgery because you think this is perforated. But regardless of what you do, once you get your imaging, if the patient is stable, you then make your decision based on what your official ultrasound shows. If you have where's my next slide? If you have negative, which starts over here on the left, if the ultrasound is negative, you have to kind of go around and look for other things that are causing this patient to have belly pain. But if you end up having a positive ultrasound, you notify radiology as well as pediatric surgery, and you go ahead with the plan to do an air contrast enema. The reason you want ped surgery involved immediately is because if you send them for pneumatic decompression and there is a complication, i.e. perforation or other surgical problem, you want surgery immediately there so that you can immediately go to the OR and fix whatever problem you initially occurred. Obviously, your unstable ones in the orange block go right to the OR for operative reduction. In the case where you have successfully reduced the intussusception, you can admit to pediatric surgery for observation, but there is a mechanism in place that is being worked on where we leave them in the ED for a short observation period and then can discharge home. If any of the other PEM attendings who are here can address where we stand on that part of the pathway, that would be helpful. But if you do a reduction and they're stable, you can always admit them overnight and have them get watched. But in discussing with surgery, if they tell you that it's okay to discharge them home, you can do them as well. If your reduction is obviously unsuccessful, this patient needs to come in for admission. They may need a repeat attempt at a pneumatic reduction, or surgery may say, we're just going to take him to the OR anyway. Interestingly enough, go ahead.
Different institutions are starting to do different things. We're still working on our pathway, but I know that you can observe for 4 hours. You just want to see if they're going to re-intussuscept, if they're able to tolerate PO. And so those are things that you work in conjunction with your ped surgery, consult. The other thing I wanted to point out is that you actually may not catch the intussusception at any moment, whether it's by x-ray, your ultrasound, or by an official ultrasound. But if if you have a high index of suspicion and or the patient is still not tolerating PO and you can't find the intussusception, you look for other pathologies, but it could still be intussusception. So you can admit just for monitoring and then reassessment.
Excellent. Thank you so much, Dr. Khan. I think that always falls back into our realm of you can bring the patient in for observation if you're concerned and you need to have an appropriate observation period going on. And that's good to know because you may not catch the intussusception on your imaging because some of these intussusceptions pop in and out. So you may be unlucky, and even though your kid has a classic story, the intussusception may have automatically reduced by itself before you caught it on imaging, but can always telescope back. If you have a kid who's 4 and up, and you know that they have an intussusception, as we talked about in our first slide, we said that once you hit like the age of 5, and in this case 4, your rate of intussusception drops a bit. So if you have someone 4 and up who has an intussusception, you need to go digging for a pathologic lead point. These are probably not going to be gesture lymphoid hyperplasics. These guys may end up having tumors, polyps, Meckel's diverticulae, something else, and you want to get additional imaging, whether it be CT or MRI, to make sure that you're catching any other pathologic lead points that may need other intervention while the patient is in the hospital. All right, so let's move on to our next topic. So passing intussusception, we go on to the appendix. We all evaluate for appendicitis all the time in all of our belly pain patients. We're always checking, oh, are they peritoneal? Do they have a Murphy? Do they have a Robsing sign? Do they have a McBurney's point? Like, we're always kind of keeping this on our differential for a belly pain. So let's talk about what that would look like on ultrasound and what we can do about it in the pediatric emergency department. So obviously appendicitis is pretty common. Interestingly, while intussusception may be more common in men, appendicitis seems to be more common in women. But the most common age group is between 10 and 19. I had appendicitis when I was 19, to give you an example. But generally, you can have appendicitis at any point during your pediatric age. It is a little bit less common the younger and younger you get, but you can still have it. In the case of an appendicitis, generally what occurs is that you have some amount of obstruction of the appendix by a fecalith or by something that causes obstruction, causes that part of the appendix to get inflamed, to not have contents moving through it very well. You get distension of the appendix, you get organ ischemia, you get overgrowth, and then you eventually get some kind of perforation. Interestingly, your little kids, like under 2 years of age, their appendix is shaped like a cone. So that you don't always get the obstruction because that entrance at the right at the cecum where the appendix is attached is a little bit wider. So you may have less chance of getting it obstructed and less chance of having appendicitis. But in a kid with a peritoneal abdomen, you still have to be concerned and consider it on your differential, even if it's less likely. Your classic kid with appendicitis often has periumbilical pain, sometimes vomiting, often anorexia, and then can then have migration of their pain from the periumbilical area into the right lower quadrant. This usually happens within the 24 hours of the initial onset. Most commonly and most specific, they have some amount of pain with movement. We often ask our patients to jump up and down, or while they're lying on the bed, you just grab them by the pelvis and shake them around. If that's hurting them, there's a sign that there's some amount of peritoneal inflammation going on. You may also end up with fevers, and then obviously you have some amount of right lower quadrant tenderness with or without some amount of peritoneal guarding or rebound. The key with the clinical presentation is that the older you are, the more classic you look. The younger you are, the more not classic you are. Your classic young child with appendicitis will have belly pain, some anorexia, mainly in the periumbilical area, and maybe having some vomiting. And you might be thinking to yourself, well, this sure sounds like a viral gastroenteritis. They often present non-specifically. So the younger you are, you have to have a different level of concern to say, well, they may have an atypical presentation. And if it's atypical, I might want to start imaging earlier to make sure that I'm catching it. But we had a case the other day in peds of I think she was a 9-year-old who came in who was having a lot of belly pain and anorexia. It ended up being a viral gastro in the end, but because she had anorexia, periumbilical pain, pain with jumping up and down, we had to go ahead and proceed with a more detailed evaluation for appendicitis. Obviously, on your exam, you're going ahead to do your tests for peritoneal inflammation. These include your obturator sign, where you do some amount of pelvis internal rotation. Basically, you're externally rotating the hip while you're internally rotating the lower leg to kind of twist the obturator muscle to see if the inflamed appendix is twiddling along the peritoneum and giving you inflammation. And then your psoas sign, laying them on the side, pulling that right leg back. And if they have peritoneal inflammation, that will cause them some amount of pain. Obviously, you have McBurney's point, your right lower quadrant area of maximal tenderness. And then one of my favorites, Robsing sign, where if you push on the left lower quadrant, you actually elicit pain in the right lower quadrant, which is suggestive of true appendicitis. And then this is where we kind of talked about the differences between kids and adults. The adults, as I said, are often very classic, while the younger kids are very non-specific. Infants often end up with distension, vomiting, decreased oral intake, and 99% of our viral gastros in little kids look exactly the same way. So you have to make sure you're keeping a broad differential. And similar with kids under the age of 5. Not advancing. So when you see these kids that are kind of non-specific, are you scared? Are you saying, is this appendicitis? Is this not appendicitis? If you have higher concern, go ahead and start the workup. Sorry? Someone say something? Oh, never mind. Either way, when you're going through the process of determining how risky it is that your patient has appendicitis, there are a couple scoring systems out there that you can use. One of the most common is the Pediatric Appendicitis Score. This assumes you've already gotten blood work, but when you have the Pediatric Appendicitis Score, you get a point for anorexia, a point for nausea, vomiting, a point for migratory pain from periumbilical to right lower, point for fever, a point, 2 points for some kind of peritoneal sign, and then points for right lower quadrant. And then if you have elevated signs of inflammation, an elevated white blood cell count, or an elevated ANC, that all starts to add up towards a higher risk of having appendicitis. If your PAS score is 7 or higher, you end up with almost like a 78 and above % chance that this really is an appendicitis. Now, the real question you have to ask yourself is, how often do I actually want to use the pediatric appendicitis score? And from my research that I was looking at, when you use the pediatric appendicitis score, it's really good when it's really positive, or really good when it's really negative. If the pediatric appendicitis score is equivocal in the middle, they really say pursue with some extra imaging to help get you some more information. This is also similar to the Alvarado score, which we're not going to go through in quite so much detail. But again, it's been found to be really good when the score is high or really, really low. But in the intermediary phase, you can't make that decision. And you have to get extra imaging or extra information to help you determine if you're dealing with an appendicitis. So when we go along with ultrasound, how do we actually do this? This is, again, using our linear probe, and I will recommend going to the adult side and stealing their large linear probe, especially in our pediatric patients. You will want to identify your point of maximal tenderness, which is often your McBurney's point, and then you start to examine at your underlying structures. The key here is you want to be able to identify your landmarks. This includes your psoas muscle and your iliac vessels. The reason you will want to identify your psoas and your iliac, and we'll show this in some pictures in a little bit, is that your appendix, in most cases, will drape itself nicely over the appendix and the iliacs, and that's where it will be most of the time. That being said, the appendix can be very tricky. It can be retrocecal, it can be in other different positions. So even if you identify your psoas and your iliacs and you don't see an appendix, you still have to go looking at other places to see that it's not there, to see that you can find it, okay? Now, to actually identify the appendix, you again use graded compression. This helps push that bowel gas out of the way. And once you identify it, you want to make sure that you're looking at it in 2 planes, longitudinally and transverse. To help you identify the appendix and to even bring it more anterior, you can put the patient in kind of like a left lateral decubic position. and that can shift the appendix into a more viewable position to be seen. Once you identify this blind-ended tube, you look for Kasich findings. You want to say that your diameter measured from outer wall to outer wall is 6 to 7 millimeters or more. You want to identify that the appendix itself is non-compressible, and then you want to identify that there's a lack of peristalsis within the appendix itself. All of this comes from the fact that the inflamed appendix gets large, and then it kind of like gets a little slow and sluggish. It stops having as much peristalsis, and you can't really push on it anymore. But if you have something that's compressible, you're probably not looking at an appendicitis. So let's look at some pictures. This is actually from a review done by Dr. Sinnert and the other people at Kings County, looking about how good we are if you have a non-compressible appendix greater than 6 millimeters. And as you can see, it has a pretty high positive likelihood ratio with pretty high specificity. That being said, the sensitivity is not over 90%. So if you miss something on ultrasound, that's because you may not be catching it, and you may have to go and get additional imaging. But if you find it with a non-compressible enlarged appendix, you're pretty sure that you deal with appendicitis. Now, what are the structures? What do they look like? So this is one of my favorite pictures. I hope you guys can see the colors on your side. But the key here is to identify which structures are which, right? So you have kind of your green psoas muscle here that has some amount of striation. You have your iliacs represented by the red and the blue, and then you have your appendix. It's most commonly found anterior or between the psoas muscle and the iliac vessels. Now, this is the most likely place that it will be, but again, you can have almost 50% or more a retroiliac or a subcecal appendix that is sitting in a slightly different position. Now, this picture also shows you what it looks like when you go from a transverse position into a longitudinal position. And here you actually get you get pretty lucky. You see kind of the multi-layered bowel wall. But what's really important at this stage is that because you have appendiceal inflammation, you may not see the traditional 5-layer bowel wall. You may just see a standard single layer wall because all the inflammation makes it all blend together. There are some articles that talk about measuring the actual single layer bowel thickness on that wall side, like the wall thickness itself. That is also less commonly done because of the inflammation, and you can't always tell exactly what you're looking at in the bowel wall itself. So the key is to measure from outer bowel wall to outer bowel wall to see if it's greater than 6 millimeters. And then always remember that it's got to be a blind-ended structure. If you can parse through it and you can see that it's not blind-ended, you're looking at some other part of the intestine and not the appendix itself. So a normal appendix, which you may not often find, is less than 6 millimeters, is compressible, has normal wall thickness. Now, if you want to measure the thickness or not, and that if you try to compare it to other parts of the intestine, they have different wall thicknesses as well. Now, as I mentioned previously, the actual thickness of the wall itself on one edge is less commonly measured in POCUS for peds. If you would like to go ahead and do it, you can. And you kind of say, well, my appendix has a wall thickness between 1.1 and 2.7. And you can try to convince yourself that it's normal. But in reality, there are cases where the wall thickness will be different than this. So you can't hold your hat on the wall thickness alone. You have to look at all the additional features. This on the bottom here shows a beautiful picture of what the 5-layered bowel wall looks like from both transverse and longitudinal. But again, you may not see this if there's inflammation. That being said, you may not see the appendix at all. If the appendix is not inflamed, your ultrasound study will be inconclusive. And we often find that a lot of our techs that do ultrasound studies for the appendix don't see anything. And then you have to say to yourself, well, if I don't see the appendix, can I rule out an appendicitis? And you can go ahead and we can discuss other ways we can differentiate appendicitis when the ultrasound is negative. Now, what are some bad findings that you want to find? Obviously, the lack of compressibility is the most important, 96% sensitive, and these are some pretty blurry pictures, but just some quick stills that show you having a non-compressible, dilated, remember, outer wall to outer wall appendix. And this is almost like a 10-millimeter appendix. This is pretty massive, considering 6 millimeters is your cutoff. And then occasionally, in addition to the non-compressible dilated appendix, you will see other secondary signs. You may see mesenteric fat stranding, you may see free fluid, All these extra signs help increase your chances of having a positive appendicitis. Some of the other secondary findings that you can really see abscess around the appendix, free fluid, maybe a little bit of perforation. You can see an epicondycolith. The cool thing about an epicondycolith is that it will have some amount of shadowing behind it. So if you see a hyperechoic structure within a luminal structure that doesn't have shadowing, that hypoechoic structure is probably poo. Sorry, the hyperechoic structure is probably poo. If it has shadowing, it makes you more concerned that it's an appendicolith. And then on all of these pictures, you see a little bit of surrounding free fluid as well around the appendix, indicating some amount of inflammation that's going on. If you're really fancy, you can go ahead and throw a Doppler on it, and you can see sometimes this ring of fire showing that the bowel wall itself is really hyper-inflammatory and there's a lot of blood flow going to it because it's so inflamed. Now, the debate that you have is, what if you do your ultrasound, you don't see an appendix, but then you're starting to look for other secondary findings? And there was a study that was done. They looked at basically 640 patients that had a right lower quadrant sonogram. They specifically identified the ones that had a normal ultrasound, and they tried to differentiate if you have secondary signs or if you don't have secondary signs, what is your chance of having an appendicitis? And what they found is that if you have no secondary signs, so no free fluid, no mesenteric fat stranding, no abscess, you have a 2% chance of having an appendicitis and 98% that you're normal. So the key being, if you don't have any secondary signs with a normal ultrasound, you can feel comfortable that it's probably not an appendicitis, okay? If you have secondary signs, even with a non-visualized appendix, you probably have appendicitis at that stage and you have to dig a little bit further. So how do we actually go and do this? This is really fun. In general, you wanna start with, you can say to them, hey, where's your point of maximal tenderness, which is often your McBurney's point, and that's where you can start your sonogram. But this technique recommends first by identifying your landmarks. So they say, identify your non-peristaltic ascending colon from that initial point of maximal pain, move inferior to try to find your cecum, then move medially to try to find that iliocecal connection point that we showed earlier on in the presentation. Now, this is very hard to do. You may not be able to identify the appendix coming off the cecum itself, but it's a thing you can try. Once you identify kind of where your terminal ileum and your cecum are, you kind of move back and forth. You're panning, you're scanning both longitudinally and transverse, trying to find your appendix. And remembering that you want to change your view. If you're doing transverse, always rotate your probe 90 degrees to see if you can catch it in another view. And this is very hard, but you have to practice in order to feel comfortable doing it. So let's take a look at what an example is. So this picture here, so I'm going to play it fast, quick. First time quickly. So you see the pulsating of the great vessels, and then popping here at the end, you see this lovely circular structure in transverse that shows what looks like almost like a little bit of free fluid around it, but shows a pretty large structure. Now, in this video itself, it doesn't show them doing compressibility, but if you were to measure this structure size, see that it was greater than 6 millimeters, and then try to compress it with your probe, and they have a lot of pain there, that's your appendicitis. And that's a pretty good positive appendicitis right there. Again, you can see it in a little bit fast video. I think it's interesting to watch it in this fast video because you get to see the pulsations of the iliac vessels. You get to see the psoas muscle over here, and then you get to see your appendix hanging out right around that same place. All right. Now, this shows you identifying that you are looking strictly at the iliac vessels, which you saw in this previous video. You saw the pulsations of the vessel, but by putting color flow over your appendix and your vessel, you could say, all right, that vessel is not an abscess, it's definitively a vessel, and then you could compare it for the size of the appendix itself. In this case, it would have been cool to see the ring of fire sign, but you don't see that here. But if you play this video, you do see that pulsation within the great vessel, the iliac itself, and then you kind of see the large appendix over here with surrounding free fluid. Now, this is what it looks like in longitudinal. again, here you would see a blind-ended structure. But what's important about this view is that you're starting to see some secondary signs. When you're looking here, you see a little bit of free fluid around the appendix, okay? Now, obviously, just like we do with FAST, if you see free fluid in the abdomen and it has that spiculated sharp appearance, meaning non-convex, nothing round, you can see here that you have kind of like this sharp appearances over here that shows that there's a little bit of free fluid. I would also say that there's probably some free fluid tracing along this bottom edge of the appendix as well here. In this view, this is where you can really go ahead and do your compression and to see if your appendix will compress itself. But this is a pretty rock solid appendicitis. And again, a thank you to Dr. Drenna for some great pictures. Now, it's always important to remember that the appendix may not be where you expect it to be. So even if you're looking right over the psoas, right over your iliac, you may actually have one that's in a different position. I apologize for the spelling mistake, but this is a retrocecal appendix. And as you slowly pan through this, you see your appendix start to pop up back down there. So you guys see this tubular structure at the bottom that has a multi-layer bowel wall, and it ends up actually protruding behind the cecum, where you would sometimes expect it to be more anterior. You just have to have a thorough evaluation to make sure you're catching an appendix in a different position than you would usually expect it to be. Now, if your ultrasound is equivocal or negative and you don't actually see the appendix, you cannot exclude an appendicitis. This goes back to what we talked about a little bit before, that if you have a negative ultrasound with absence of secondary findings, that only 2% of those cases end up actually having an API, that's fantastic. But if you have a negative ultrasound and it shows any kind of secondary findings, you need to be more concerned and do additional studies. So the question becomes, what additional study do you get? Do you do CT? Do you do MRI? Do you do oral contrast, IV contrast? What do you actually do? In the best case scenario at a really great center, you're going to have a fast MRI. A fast breathing MRI can take 20 minutes, highly sensitive, and it can be very quick to identify an appendicitis. I know that at previous centers I've worked at, we've done these fast MRIs, give the kid a little bit of intranasal Versed if they're really little, papoose them up if they're really little, get them really calm, and you can get a much better look at the appendix. In our realm at County, you're probably not going to get the MRI pretty quickly, so you're going to go ahead and do a CT. And then when you're doing the CT, you're going to add IV contrast to it. Now, some places will also add oral contrast on top of the IV contrast. If you think oral contrast may be necessary, obviously speak with radiology. I have very rarely at County had them ask for oral contrast, but there are other centers where IV and oral for CT are required. But let's see, what does an MRI actually look like? These are gorgeous studies, right? Your CT scan, while it may be higher resolution than your MRI has better soft tissue contrast. So you really can see this appendix on your MRI, indicating that you have a large inflamed appendix. And when you do the MR, you often see a lot of those secondary signs: mesenteric fat stranding, surrounding free fluid, surrounding abscess. And these are all different versions of like different scans within the MRI itself. This bottom one being really grainy because it's a diffusion weighted imaging. And that if you have inflammation, you tend to have more diffusion or more fluid movement around the appendix itself, while the rest of the structures will show less fluid movement, so less diffusion. But this is a pretty high level thing. The key really is looking at the other images and saying, oh, wow, I see a really large inflamed appendix. If you can get the MRI, go for it. If you can't, CT does work, but again, has radiation and has the risk of radiation. Now, to manage these patients, obviously, keep them NPO, give them IV hydration, make sure you're resuscitating them with the fluids, and then you're going to start antibiotics. You want to start generally ceftriaxone or ceftriaxone with flagyl or flagyl by itself. If you're starting antibiotics, and we'll talk about this at Kings County, you want to discuss with the surgeons. Some of the surgeons have different antibiotic regimens than what we would generally start for broad spectrum antibiotics. And then they would make the decision to go ahead to the OR. They tend to do laparoscopic removal. It's associated with shorter length of stays, lower risk of infection. But if there's a concern that there's perforation or other bowel injury, they'll just do an open procedure to make sure that they can run the bowel completely and make sure there's no other signs of infection. Interestingly, there is a new movement. It's not really that new anymore, but they often do non-operative management with IV antibiotics prior to then taking out the appendix. Some centers do this primarily, but it depends where you are. But the key here being that operating on an inflamed, nasty-looking appendix may cause more complications. So often they will start antibiotics. Then after the appendicitis has simmered down, then they will go in and take out the annoying appendix that caused all the problems. These guys have less complications, but in some cases can have more recurrence because you're not immediately taking the appendix out right away. But depending where you practice, this may be the routine. Just again, talk with your surgeons. At Kings County, we are currently actually working on updating our appendicitis pathway. But in the current version of the pathway that we have on SharePoint, as well as in our book, if you suspected appendicitis, obviously place your IV, get your labs, fluid resuscitate, give appropriate analgesia, and make them NPO. You can go ahead and get your imaging. A KUB can be done at this stage, but generally you're going to end up going for the ultrasound. If your ultrasound is definitively a positive, go ahead and admit them to surgery. And at this point, call surgery and find out which antibiotics they want. I know that with our change in our pediatric surgery team that is covering us here at County, our choice of antibiotics has changed slightly. And I know that we end up using more Flagyl with different frequency than you would normally be used to with some of our surgeons. So you just have to make sure you talk to the surgery team so that you're antibioticing appropriately with what the surgeons would like. At other centers where your surgeons may be less picky, you're generally okay to start some amount of ceftriaxone Flagyl to cover enteric flora and anaerobes. Obviously, with labs, you're getting your inflammatory markers. And then at this point, if you really think that something is surgical, you're also getting the pre-ops, mainly just like a type and screen, because they're going to be going to the OR. We have found that there's less utility in getting pre-op PT, PTT, and INRs in these patients going for surgery because the actual coagulation parameters, PT and PTT, are not really that helpful for identifying risk of pediatric bleeding. In reality, the most common pediatric bleeding disorder is going to be von Willebrand's, which has normal PT and PTT. So sending the actual coags themselves has been found to be less useful, and we are moving away from sending them in RED. And even our anesthesia team agrees you really don't need them. Now, if your ultrasound is inconclusive, this is the point where you have to go ahead and talk with surgery in a little bit more detail. Surgery will come down, assess your patient, and they will help you decide to get CT imaging. And then with your CT findings, you can decide to admit them if it's definitely positive, or you can sign to do PO trial and determine where the patient is going to go. If the patient has persistent pain, not tolerating PO, and they don't look great and their belly doesn't look great, bring them into pediatrics. Now it says admit, but in this case, you could bring them into observation so that you have a less than 48-hour stay, and you can do serial abdominal exams. Surgery can follow them, the peds team can follow them, and if the abdomen exam worsens, they can then decide to repeat imaging or go to the OR at that time. If their pain is getting better, they're tolerating oral fluids, then you can set them home. Down here, we have some of the recommendations for the antibiotic regimens. But again, these are slightly changing with our new pathway that should be coming out. I'm not sure when the start date for that new pathway will be, but there are some debates about what should be going on in the antibiotic realm.
Yeah, it's Mona. So I wrote in the chat. So the ceftriaxone Flagyl is okay if they're healthy, no allergies, and it's uncomplicated. But I would keep an eye out because it's being reviewed by surgery as far as the latest pathway, and it'll be updated. And then I just wrote some recommendations in the chat. So as far as CT, spoke with radiology, and with the younger kids, they would prefer having PO and IV contrast. However, if the patients are larger, comparable to an adult size, then you can forego the PO contrast. And with MRI, you can have a discussion with radiology depending on the time of day, and really advocate for the patient having an MRI. And it's definitely worth a try and a discussion.
Yeah, MRI is a fantastic test. Remember, you have no radiation. Yes, a CT could be minutes, while a MRI could be more like 20 to 30 minutes. But the MRI may end up being the gold standard at places that have rapid access to MRI. And if it's during the day, we can get MRIs from our pediatric ER. It has happened, and it has definitely been done.
The only two problems with MRI is the age. So I think under 8 or even under 10, it can be quite scary for them. So they might need sedation, and we can't send somebody to sedate them. And 2 would be if they're COVID positive, they get pushed down to the end of the day so that they can have the contaminated patients. So you have to keep that in mind right now.
Oh yeah, we had that recently, actually, like a concern for Appy, and then we ended up wanting to get the MRI, but because she was COVID positive, they got pumped. So then we just did the CT anyway. But it's worth it to get the MRI, because I feel like if you continue to push them to do the MRIs, everyone gets more comfortable with it and we get more use out of it. And then maybe it becomes our gold standard if we have 24-hour MRI techs eventually. Thank you everyone for their input. So let's conclude for the day. The takeaways that I pull from this is that when you're examining the abdomen with an ultrasound, you want to know what normal looks like. And this is always the case for everything, but you have to feel familiar knowing what normal bowel looks like, normal gas looks like, and normal poop, so that when you do these studies, you're not like, oh my God, look at all of this like extra hyperechoic stuff. Is this an appendicolith? Is this free air? Is there something else going on? The more you do, the better you become. In this realm, it's also important, you do not want to be super quick with doing these scans. You do not want to pan through the abdomen at a rapid pace. Go slowly. Really use graded compression. Push down, push that bowel gas out of the way. Look with detail and slowly so that you can try to catch what you're looking for. The faster you go, you'll probably miss something. For your intussusception, you mow that lawn. You start in the right lower, go up, down, up, down, up, down. And then once you hit the left upper, start from there again, change your probe to a 90-degree from the original, and then go back and lawnmower the belly again. The more thorough you are, the more likely you are to find your target sign. And then for the appendicitis, the key here is looking for that 6 millimeter or more outer wall diameter and the lack of compressibility. And once you see that, you're feeling pretty positive you found yourself a positive appendicitis. But again, if your ultrasound is negative, you have no secondary findings, i.e. abscess, free fluid, appendicolith, or anything like that, then your chances of appendicitis are much lower. And those are the kids that, if they're having poor tolerance to oral intake, would benefit probably from either a prolonged ER observation period or just bringing them in for observation overnight for repeat serial abdominal exams. Again, if they end up declaring themselves and their pain gets worse, you can always image them again and get them to the OR on the appropriate time frame. So that's all I have for today. And I really want to thank Dr. Drennis for his images. If any of you had a chance to work with Dr. Drennis in our PEDS ER, his ultrasound skills are spectacular. He will look at anything with you in exquisite detail. Just ask him. And he's got lots of old studies from his time when he was a fellow. So does anybody have any quick questions?
Quick question. Before we mow the lawn on these kids' abdomens, I'm assuming we give them pain control. What is the go-to? Is it ketorolac? What dose?
So if you're going to use ketorolac, you're generally going to use like the 0.5 per kilo. But you want to go ahead and start with, you don't really need the big dose. You could, like, your adults that are really, really unwell, like you're generally still giving them like 15 to 30 IV, but you do the weight appropriate dose for ketorolac by IV. And if you don't want to give the ketorolac, you can even go ahead and give them morphine. If their belly pain is really, really severe and you know that their pain will limit your sonogram, appropriately analgesize them early so that you can get good pictures.
Yeah, I feel like morphine is pretty common.
Yeah, I've definitely used ketorolac, but if you're concerned enough that they might go to the OR, you're concerned about giving something that may cause bleeding, but morphine is usually pretty much your go-to.
We're talking about intussusception kids?
pain management in general, but intussusception in particular.
Oh, because I mean, if these kids typically Tylenol or Motrin, because at that point, you probably, I don't know if most of them, I haven't even gotten an IV yet to give them morphine or Toradol, and I don't think I've ever given a kid morphine for that initially.
Yeah, sorry, I thought we were talking about appendicitis. Yeah, for intussusception, I would do.
Yeah, no, because we brought up mowing the lawn, which is more of a intussusception, but those kids, you obviously want them to be calm, because the more they cry, the more difficult the scan will be, because they'll just have a lot of air. They'll have a tense abdomen with their crying. So you want to just try to keep them calm as much as possible. And yeah, just one thing, just remember, the more of these you do, the better you're going to get. Most of the literature supports that an experienced point of care sonographer will be just as good as radiology. And most of the numbers are usually at 25. So if you've done 25 scans, you have a good portion of them being positive, then you are credentialed, I mean, up to the institution, but you are almost as good as a radiology tech or a radiologist. I've had ultrasound techs come down in Coney Island with a picture of intussusception while they were scanning. So don't assume they are better than us, but the more you practice, the better you'll get. And depending on what institution you go to, right, you might be the only person to do this sonogram.
Yes.
I really liked the discussion that's going on in the chat about different analgesic methods. I do agree with both Liv and Tasso about using oral in some of these intussusception patients, because you have unlikely put an IV in them at that early stage. So giving them a little bit of Tylenol or Motrin is not the end of the world, especially because most hemodynamically stable intussusceptions do not undergo open or laparoscopic surgical procedure. So you're not really worried about their MPO time. So you can always start with a little bit of oral. If you identify anything positive or concerning, obviously make them NPO for the rest of the ER stay, but one dose of Motrin right up the front isn't going to be the end of the world. And then I see some people talking about intranasal medications. Intranasal fentanyl, intranasal definitely works. As Rosie was saying, it does burn a little. It can make the kid cry a little, which can obscure with a lot of air in the belly. But always worth the try to try the intranasal medications, especially if they're really difficult to put an IV in.
Yeah, it's always an option.
Yeah.
And just remember, have a higher index of suspicion for kids under the age of 5. Most of the time when you find an appendicitis in these kids, it has ruptured. And so they may not follow the same path as like a 10-year-old.
Yes, thank you, Dr. Khan. It's really the young kids that are non-classical presentations that should perk up your ears and make you dig a little bit further. Thanks, everybody.